Hello, my name is Hasan Ersöz. I am a thoracic surgeon focusing on chest wall deformities in Turkey. This study was conducted by an experienced team at Fundación Hospitalaria in Buenos Aires, Argentina. For many years, our evaluation of pectus excavatum has mainly relied on depth basis indices. However, the longitudinal extent of the deformity has been largely overlooked. This study addresses that gap, introducing a new parameter for a comprehensive assessment. Let's take a closer look. In clinical practice, we commonly use the Haller index and the correction index. Both of these indices evaluate the deformity only at its deepest point. They do not tell us how much of the sternum is involved along its length. And this is actually very important for surgical planning. The authors introduced a new parameter called the Titanic index. It represents the percentage of sternum and lies behind the anterior costal line on CT imaging. In simple terms, it measures how much of the sternum is sunken along its length. So, unlike existing indices, this one focuses on extent rather than just depth. This is a retrospective study including 78 patients with a mean age of around 17 years. Patients were divided into two groups, those requiring 2 bars and those requiring more than 2 bars. The Titanic index was compared with the Haller index and the correction index using CT-based measurements. The mean Titanic index was approximately 67%. It showed correlation with both the Haller index and the correction index. But more importantly, it was a much stronger predictor of the need for more than 2 bars. Patients requiring more than 2 bars had a markedly higher Titanic index than those in ROC analysis, that is receiver operating characteristic analysis. The area under the curve for the Titanic index was 0.97. This clearly outperformed both the Haller index and the correction index. A cutoff value of 66.5% predicted the need for more than 2 bars with a sensitivity of 93% and a specificity of 92%. Clinically, this is very relevant because it helps anticipate whether more than 2 bars may be needed before surgery. This improves planning and helps prevent undercorrection. Especially in more complex patients, the authors specifically highlight its value in patients in whom intraoperative judgment may be more difficult. So essentially, traditional indices focus on depth, whereas the Titanic index adds the dimension of length, and together it provides a more complete evaluation of the deformity. Of course, this study has limitations. It's retrospective, single-center, and partly depends on surgeon decision making. Also, because this center routinely uses at least 2 implants, generalization to other bar strategies should be made with caution. So further prospective validation is needed. In conclusion, the Titanic index is a simple and reproducible parameter that adds a missing dimension to pectus evaluation, and it may help us move toward more precise and personalized surgical planning. Thank you for your attention, and I would like to thank the CWIG community for the opportunity to present this valuable study.